Good morning, everybody. Good morning. Welcome to Grand Rounds. My name is Dana Williams. I'm a pediatric gastroenterologist for those of you who have not met me yet. I am delighted to introduce today's speaker. Dr. Susanna Ha is an old friend from fellowship, but also an amazing scientist, clinician, lecturer. She has agreed to speak today in honor of Mike Shelton. For the last couple of many years, the Shelton family has sponsored this wonderful opportunity to remember Mike Shelton, a former colleague in our division. He was in our division in the mid-90s. He trained at LA Children's with wonderful gastroenterologists, Danny Thomas, Frank Sinatra, Russ Merritt. And he had an interest in pediatric nutrition. And his mentor, a well-known pediatric gastroenterology with huge expertise in nutrition, Russ Merritt. Mike helped run the division, the nutritional support in the division when he was in LA, and then moved to Phoenix Children's in the early 90s. Unfortunately, he passed away suddenly. He became ill and passed away suddenly in 1995. His family was very generous in sponsoring donation for this lectureship. Mike was a wonderful person, a great colleague, always had a great smile on his face, and was loved by his peers and his family. He, over the years, some speakers for this lectureship include Barry Warshall, Glenn Ferruta, Danny Thomas, Phil Rosenthal, Rob Schulman, Phil Sherman, and Jeff Hyams. And I am just absolutely delighted. I didn't even realize Dr. Ha would be our first female presenter for this wonderful opportunity. Dr. Ha is coming to us after completing her training in immunology computer engineering in Canada at the University of Toronto. She earned an MD degree at the University of Western Ontario in Canada, and an MPH in clinical effectiveness at Harvard School of Public Health. She completed her residency and was chief resident at the London Children's Hospital in Western Ontario, and went on to complete a clinical and research fellowship at in the Division of Pediatric Gastroenterology and Nutrition at Boston Children's Mass General Hospital. She has been faculty at Boston Children's Hospital and Harvard Medical School since 2011, and is an assistant professor of pediatrics at Harvard Medical School currently. She has an incredible expertise in the area of nutrition. I'm just going to point a few things that she has wonderfully completed. She directs the growth and nutrition program at Boston Children's Hospital, and is associate director for the clinical nutrition services. Her various research has included maternal protein intake during pregnancy, fetal exposure to glucocorticoids, and blood pressure levels of infancy. Earlier on in her training, went on to do a lot in the area of epidemics of child obesity and her studies. Currently, she is a co-investigator for the Project Viva, which, in which she leads several epidemiologic analyses on the timing, on the modifiable risk factors for childhood obesity, including mode of delivery, timing of solid foods introduction, and child dairy intake with adiposity. Her research presently focuses on the identification and management of childhood malnutrition, and she manages and directs the she's a director, of the Growth and Nutrition Program, which is a multidisciplinary program offering various treatments and diagnoses for children with failure to thrive and feeding difficulties. Additionally, Dr. Ha is a wonderful clinician, has an incredible has done incredible activities of mentorship and in training. She is a mother of 2 wonderful children. I got to hear some updates, and motherhood is the same in Phoenix as it is in Boston, so it's kind of nice. And I'm just delighted that she's with us today. Please welcome Dr. Ha.
Yeah.
All right. Thank you so much for that very kind introduction. And I want to thank Dr. Williams, Dr. Silber, Dr. Chubb, all of the organizers in the medical education, as well as the GI departments for inviting me here and for giving me the opportunity really to speak in honor of, sounds like a really wonderful colleague, Dr. Mike Shelton, and someone who, and it's a special delight to be able to speak on inpatient malnutrition detection and treatment in honor of his memory. Oh, I'm sorry. In terms of advancing, should I use this? Yes. No? How do I advance? Oops. I was trying to. Yeah, nothing is working. So.
Matt, where? There we go.
Sorry, this one? Up and down? Okay. All right. Okay, great. Okay. All right, so I'll cover a few questions pertaining to malnutrition detection and treatment in inpatients. First, how common malnutrition is in hospitalized children, how we define and diagnose it. I'll focus on a few specifics about a project that I'm leading to improve malnutrition identification at Boston Children's Hospital, and then what can we as physicians do to improve malnutrition detection and treatment, both at an individual level as well as at the institutional level. So I'd like to begin with a case. This is a real case that presented at Boston Children's Hospital. And as an adult, he was followed for a long time at Children's Hospital. He actually has HIV and a number of complications related to that. And he came to the attention of the Nutrition Support Service after he was close to 19 years of age. And prior to that, for a little over a year, he actually went from being 95 kilograms to 52 kilograms. And by the time that we met him, he was actually admitted for severe vomiting. He didn't tolerate NG tube feeds, and during the course of that admission, it turned out that he had actually SMA syndrome and ended up admitted to the hospital for 3 months. During a portion of that time, he was enterally tube fed, ended up eventually getting a GJ tube, and he also required parenteral nutrition during a portion of that admission. And what I want to highlight is that he actually was admitted on 5 separate occasions during that year prior to that final admission. And during none of those admissions addressed nutrition explicitly as a problem. And in my opinion, I would pose to you that these were opportunities lost. And potentially, if nutrition had actually been explicitly addressed during one of those admissions, there might have been an opportunity to either reduce the severity of the final presentation or even prevent it altogether. So malnutrition and the problem of unidentified malnutrition in inpatients has really gotten a lot of attention from the national organizations that deal with malnutrition. This is actually a poster released in support of Malnutrition Awareness Week, which was September 19 to 22. And the American Society for Parenteral and Enteral Nutrition released this graphic. Now, this applies to adults, but the statistics are really striking. So hitting the highlights here, what they state is that a decade ago, 14 hospitalized patients with malnutrition went undiagnosed every minute in the United States. And today, they estimate that every minute 10 hospitalized patients with malnutrition still are not diagnosed. So although we've made a lot of strides, we still obviously have quite a ways to go. And this has real implications for patients. Malnutrition at admission has been called the skeleton in the closet decades ago by a prominent voice in nutrition, and it still kind of remains that way today. We think there are data that suggests that malnutrition at admission predicts increased morbidity, longer length of stay, higher hospitalization costs, and higher readmission rates. And while still the majority of these data are in adults, there are mounting data in children that support the same kinds of findings. The other important thing is that conversely, if you identify malnutrition early and you treat it, there is a substantial amount of data in adults that supports that you can reduce the complication rate. So identifying it and treating it effectively can make a difference. And in children, what do we know so far about the prevalence in inpatients? So there was actually a study published just this year where they looked at hospital administrative data, and what they showed was that of 2.1 million pediatric hospitalizations that occurred between 2002 and 2011, on a yearly basis, between 2 and 4% had ICD-9 codes for malnutrition. Now, we think that this is just the tip of the iceberg because most malnutrition is not being captured by ICD-9 codes, because if we're not recognizing it, we're not coding for it. And when you look using clinical measures, using higher quality kind of research approaches, the prevalence is actually closer to 7 to even as high as 1 in 3. And in 1995 at Boston Children's Hospital, there was actually a one-day study where they went around measuring as many inpatients as they could. And in that study, they showed that 1 in 4 met criteria for acute malnutrition in the hospital. But this prevalence is even higher if you look at it specifically by specific diseases where the risk of malnutrition may be even higher. This was a large prospective 14-center study conducted in Europe fairly recently where they looked at over 2,500 admissions, and they actually managed to measure everybody within 24 hours of admission, which is actually quite a feat in and of itself. And what they found was a prevalence as defined by a BMI Z-score of less than -2 in 7% of those admissions. And this, and if you had a BMI Z-score of less than -2, it was increased to, it was linked to an increased length of stay by 1.3 days in the case of moderate malnutrition and 1.6 days in the case of severe malnutrition, echoing the data that have been published in adults. So over the past few years, there's been a move to redefine malnutrition using etiology-based definitions. And
There we go. Whoa.
Okay. And the reason why there's been a push towards this is so that we can compare apples to apples in studies. We want to all be talking in the same terminology and language in order to make advances in the field. And so people have come up with these concepts of illness-related versus non-illness-related malnutrition. So non-illness-related is the lack of nutrition being provided. That's often the main reason in developing nations. But in the hospitalized pediatric patient in the developed world, it's typically more illness-related. And illness can obviously cause a decreased appetite and pain and a reduced desire for food and reduced tolerance, but it also can be associated with other mechanisms like malabsorption, hypermetabolism, and altered utilization, often related to inflammation. One of the terms that we're trying to get away from and that I would, again, suggest that you try to avoid is failure to thrive. But ironically, just this past week, the New England Journal of Medicine published a case report where the title is "A 19-month-old girl with failure to thrive." So we're really trying to avoid this because A, this term can come across as very pejorative to families, and B, it's not precise. And one of the problems with trying to interpret the literature in the past is that everybody defined failure to thrive a different way. So being able to define malnutrition concretely using the same terms is really important. Now, why is malnutrition difficult to actually diagnose? And one of the primary reasons is that you need measurements and you also need calculations, and ideally you need more than one of these over a period of time. And while this sounds very simple, it's actually not that simple in the hospital setting, as I'll illustrate. So here are some of the definitions that have been agreed upon in a consensus statement that was released in 2014. This was a consensus of ASPEN, the American Society for Parental and Enteral Nutrition, as well as the National Association of Registered Dietitians, and also endorsed by the American Academy of Pediatrics. And in it, in the first 3 rows, you see definitions for malnutrition if you have a single indicator, meaning you have a single time point measurement. You can use weight for height BMI Z-score, length or height Z-score, or mid-upper arm circumference. And the nice thing about these definitions is that they're pretty easy to remember because the Z-score ranges are the same for mild, moderate, and severe. And they're also congruous with the World Health Organization's definitions of moderate and severe malnutrition. If you have at least 2 data points, you can use some of the next 2 rows, the weight gain velocity or the decline in weight for length or weight for height Z-score. So look at the trajectory changes to meet definitions. And then in the final one, if you have the ability to calculate whether their energy or protein intake is a certain percentage of their estimated need, then you can also use that. And just to highlight again, a small point, but still I think an important one, accurate measurements do matter. These are the same patient who we evaluated in our clinic, measurements that were followed on the left in their primary care physician's office and on the right, our office, and we use a stadiometer, and most likely the PCP used pencil and paper. And pencil and paper where you draw, I'm sure everybody knows what I'm talking about, 2 lines on the sheet of paper that is covering the examining table. And what you see is that there actually is a difference. They measure taller on this particular child in the pencil and paper method. And what that implies when you look at weight for length is that because they're taller, their weight for length is actually lower. And they're meeting criteria for malnutrition here, for moderate malnutrition, even though on our chart they're not. So those they may be subtle differences, but in a small child that can make a difference in terms of whether you're diagnosing malnutrition or not. So the other thing that matters when you're diagnosing malnutrition, because we're talking about measurements, is which growth chart should we use? And I just want to review a few concepts around the definitions of growth charts. So there are 2 types of growth charts. There's growth standards and growth references. And growth standards are an aspirational standard. That is trying to describe how children should grow if you provide optimal environmental, health, and nutritional conditions. Whereas growth references describe how children actually grew at a certain point in time. Typically for growth standards, they try to be multinational, include diverse race ethnicities, and for growth references, they often also are nationally representative data sets. And the classic examples here are the WHO growth charts are a growth standard, and the CDC charts are a growth reference. But also condition-specific charts, for example, Down syndrome, Noonan syndrome, and many other condition-specific charts are typically usually growth references. And that has implications for how you interpret things. And what I'd like to do is review in a little more detail the difference between the CDC and the WHO growth charts. So the CDC is a growth reference, and they use data from NHANES, a nationally representative data set, over a number of years from 1963 to 1994. And they intentionally chose an older time frame because, as you might imagine, if we used a more recent time frame, that data are going to be very shifted because of the current obesity epidemic. So that's one thing. The WHO, in contrast, recruited patients from 6 different cities across the world. They intentionally tried to include every continent, and the U.S., Davis, California was one of those sites. They purposely made the decision to do longitudinal data. So they took each child who was enrolled and measured them at several time points over the course of the first 2 years of life. So they created an actual growth curve for each child who was enrolled. This contrasts with the US data set, where for CDC, what they took is a bunch of kids at a bunch of different ages and then plotted them on charts and then made growth curves out of those charts. But they're not combining growth groups from each child. They're combining cross-sectional data of children at different ages. The other big difference is that 50% of the kids in the CDC growth chart data set were ever breastfed, and only a third of them were still breastfeeding at 3 months of age. Contrast that with WHO, where 100% of the children in this data set were breastfed at initiation, and they were also still being breastfed at 12 months of age. So one of their hypotheses is, would children who grew after being breastfed versus compared with those who were being predominantly formula fed, would they grow differently? And, you know, I thought I had a slide for that, but maybe not. And what they actually did show is that they do grow somewhat differently. Breastfed infants do have a sharper peak at the beginning, and then it sort of tapers off. And what happens with that is that it leads to a difference in the prevalence of low weight for age. And this illustrates, if you focus on the bars in the middle, that if you use the CDC charts to diagnose underweight, you are going to diagnose it 2 to 3-fold more frequently than you would if you use the WHO charts for children under the age of 24 months. One of their other hypotheses was, do children of different race ethnicity grow similarly if you provide them with the same environmental conditions? And indeed, their data support that concept, because if you look at these curves for mean length, stratified by each of the different countries, what you see is that the curves are almost perfectly superimposed on each other, supporting, again, the concept that children of different race ethnicity will grow similarly early on in childhood if you give them the same support nutritionally and health-wise. And more recent data still recent data still support this concept too. These are actually data comparing Chinese national reference data with the WHO standard. If you look from 0 through 6 years, again, the percentiles are very superimposed. They're very close. Now, if you look further out into adolescence and adulthood, the curves do start to deviate from each other, particularly with regard to stature. So that may not hold true later on in childhood, but in early childhood it seems to hold true. Because of the challenges in obtaining lengths in the hospital setting, but also out in the community where they might, they're not necessarily going to have access to weight and weight for height Z-scores, especially in developing nations, the WHO has really pushed for other measures of malnutrition, and MidUpper Arm Circumference is one of them. They've devised this very simple paper measurement device. It's just a tape, but it's made out of paper, and they're very cheap. And anybody can be used to train these things because they're trained to use these things because they're color coded, for yellow meaning the moderate malnutrition and red meaning the severe. And these cutoffs were chosen because they correlate well with mortality. And interestingly, while they do correlate with weight for height Z, they don't correlate perfectly with weight for height Z. And this might be useful to us in the hospital setting. Perhaps some of your dietitians are already doing arm anthropometry, particularly for children who are bedbound, or if they have contractures where weight for height Z or height in general is just not going to be as useful a measure. It's also useful in the setting of edema or ascites. And there now are actually curves available for the mid-upper arm circumference. These were actually comprised, again, using NHANES data for CDC between 1 to 20 years of age. And the WHO also has data for 6 months through 5 years of age. You'll notice that in those groups, the 6-month, 0 to 6 months is actually excluded. And one of the reasons is that the assumption from the WHO is that in that age group, because they advocate exclusive breastfeeding through the age of 6 months, that they didn't, they assume that if you're able to successfully do that, there's kind of a little bit less of a need to measure them. But there have been data recently where they've pushed to look at whether mid-upper arm circumference is a valuable measure in that group of infants, and what they show is that mid-upper arm circumference and weight for age Z are actually pretty well correlated with each other. Those are the blue and the green bars here when you look at their relationship with inpatient mortality in the developing nation. And weight for length Z was actually less correlated. So I think it's emerging that they probably measure slightly different aspects of malnutrition, and they're really complementary measures to each other. So in keeping with this need to increase our awareness and recognition of malnutrition in the inpatient setting, as well as in the outpatient setting, Aspen also released other posters that state if it was easy to see, it would be easy to diagnose. And how well are we doing? Well, we do have a little bit of data, and it's really not great. I want to go over this study in a little bit of detail. It actually is in adults, but I think it provides some useful insights into us, because what they did in this study is they took 395 adults in a hospital in the Netherlands, and they tracked these adults through the process of referral to the inpatient admission, the inpatient admission itself, and then what happened at discharge. And they reviewed all of the documentation at each of those stages pertaining to the hospitalization. And they also had an independent observer go in and follow these patients and measure them if they weren't measured, and also administer a nutrition screening questionnaire. And what they found was that for the independent observers, they detected that 1 in 3 were malnourished. 0 of the referral letters mentioned malnutrition. Of those who were malnourished at admission, less than half were weighed once, or they were perhaps not even weighed at the when they came into the hospital. The BMI was recorded in 6 of the malnourished patients, and only a third of the 126 malnourished patients were even seen by a registered dietitian during the course of their stay. The discharge summary only mentioned a minority who received nutritional intervention, and very, very few patients had it mentioned in terms of nutritional follow-up. And here, when you compare of those who were malnourished to the entire population of 395 patients, really you see that the fact that they were malnourished did not have a huge influence on whether they had their nutrition assessed or intervened upon during the course of that admission. And lest we think we're doing much better in pediatrics, there are some limited data in pediatrics that also show similar types of trends. In 2013, this was just a brief report that was published where they audited 50 kids admitted to a hospital in the UK. And this hospital did, just like US hospitals, have a policy of nutrition screening on admission. Of those 50 kids, 49 did have their weight measured, but 8 of those were plotted on a growth chart. 3 had a height or length measured. None of those were actually plotted on a growth chart. And 2 of the 18 patients older than 2 years for whom a validated nutrition screening questionnaire was supposed to be measured as per policy actually had it done. And 1 of those was considered to be medium risk and should have seen a registered dietitian during their admission had that process actually occurred. And in a different study in the Netherlands, they found that in their hospital study, again, only a third of the malnourished children actually received nutrition support during the course of their admission. So I have to say that this data doesn't surprise us, because at Boston Children's, we're not doing a great job ourselves at identifying malnutrition, and so we've launched a quality improvement project to try to improve our rates of malnutrition detection and treatment in a systematic fashion over a number of years. So Boston Children's Hospital admits about 25,000 patients yearly, and the bulk of these are to non-ICU settings. And if we estimated that 7% is actually the rate at which we would diagnose moderate or severe malnutrition in those non-ICU wards, that would amount to approximately 1,500 inpatients per year. And when we ran through some very crude calculations, if we were able to shorten the stay of even 30 kids, so that's not a hugely ambitious number, that's 2% of those 1,500 kids, it would still substantially impact hospital charges. So how are we doing? So the reason we launched this project is that what we found is that we're really not measuring height very well across the hospital. So these are data from 2005, from the year of 2005, and you can see here that we're capturing height in less than 40% of our inpatients, and as a result, we're really not being able to capture BMI, because by definition you need height to be able to do that. And what are the barriers to measurement that we've come across in the course of this hospital? Well, first of all, as we all know, the patient population is a challenge sometimes to measure height, as we've seen. They might be critically ill, they might have casts, they might have post-op restrictions where they have to be positioned in a certain way. If the family is at the bedside, they may also influence, saying that they don't want the patient to be disturbed, especially if they're there for a limited period of time. There's also barriers to just measuring them even if you want to do it. So this is actually a floor map of one of our wards that was a pilot ward for our project. And what we found is that the T's indicate the locations of where the length boards are. So you can see there are 2 T's there. But the reason why they're labeled with T is because they're also treatment rooms. So if you need blood drawn, for example, that's where the kid goes. And what the nurses were telling us is that some kids hate that room. They do not want to be taken there to go to to have their measurement taken, because they are traumatized by the idea of having blood drawn, when in fact they were just going to go there to have their length done. It's very far from some rooms, but the length board is also very heavy. So to cart it, if you're located super far, you're not going to be that motivated to do that, especially if you don't think it's that important a thing to do. So this really, as we walked around and did these walkthroughs, we realized that there really is this poor efficiency. It's not a patient-centered design, and there are changes that could be made to try to improve and support that process. Furthermore, in terms of calculating BMI and also entering the data for heights, we realized that there are many barriers that stem from the electronic medical record. And just as an example, one of the things that has plagued us has been the fact that you had to enter length or height and the weight in the exact same entry form in order for a BMI to calculate, which seems ridiculous in this day and age, but that was the way it was. So 5 minutes later, if you entered the length, a BMI would not auto-calculate. And you would have to manually do this thing, which is obviously a huge barrier to having calculated BMI. So these are just some of the things during the course of the project that we were able to work on and fix. We expanded that time window to 24 hours, so that now if you have a length or a weight done within 24 hours of each other, a BMI can auto-calculate from that, as well as a variety of other measures that dealt with workflow enhancement to facilitate this. So there's a couple of quotes that are really relevant from the quality improvement gurus. One is that every system is perfectly designed to get the results that it gets. The second is, if you pit a good performer against a bad system, the system will win every time. And what we've really tried to do is help by trying to improve the system on our pilot wards and then advancing that throughout the hospital. So we started out this project by establishing multidisciplinary champion teams on 3 different pilot wards, and we specifically chose wards where they had poor measurement rates in the hospital, because some wards were obviously doing better than others. And these wards were an orthopedic floor, a cardiac floor, and a medical surgical ICU. And we attempted to identify both ward-specific as well as hospital-wide barriers to obtaining and documenting measurements. We did this through a combination of methods, just brainstorming sessions as well as doing walkthroughs and also observation, and incorporated multiple tests of change. And this is just a graph from one of the pilot wards. This was our orthopedic floor. And what you see is that when we launched this project, we established the initial champion team meeting in May, late April 2016. And just the establishment of that champion team and engagement of that frontline staff, and I have to say that nurses were really the big champions here, and we're really grateful to their support for this project. That establishment of the champion team alone led to a substantial improvement in these measurement rates. But if we close up on the actual project and some of the interventions that we did, it's taken a fair amount of time for us to get to our target, which was 80%, which is represented by that green horizontal line. And the kinds of interventions that we've done have been things like, initially there was a drop after that big gain from the champion team establishment because a number of engaged staff left. So that posed a challenge in terms of retraining. We also started providing biweekly compliance reports and daily reports of who had or didn't have a BMI. They designed kind of a new training process and also some redefinitions of some of the staff roles pertaining to clinical assistants. They discovered that there was a standing scale that they used to own and somehow got moved to a different ward, and they brought that back over to their ward. And with all of these incremental changes, we were able to hit the target, but as you can see, we still have a ways to go in terms of proving that it's sustainable. So 2 out of the 3 pilot wards, we found that just the establishment of the champion teams alone was associated with a big improvement in measurement rates, but I actually think that's an important yet very simple intervention that we can also do, just being aware of the issue and engaging our staff in understanding that this is important to do despite all of the competing priorities. Taking care of an acutely ill child can make a big difference. And then making other incremental changes to the system to enhance the workflow and build it into the workflow is also really helpful. So I just wanted to highlight, this is actually literally just the first step in our project, and what our hope is ultimately to, once we improve our ability to actually measure patients across the hospital, then to actually implement rapid action after that occurs. Once we detect malnutrition, to be able to notify the relevant staff, especially registered dietitians, to be able to do that in an automated fashion, and then to initiate a malnutrition care plan that will actually allow us to track whether we're delivering the appropriate nutrition to those malnourished patients. So in the last portion of my talk, I want to just touch upon what can we as physicians do to improve malnutrition detection and management for these inpatients. And I want to go back again to that case that I started off with, and I would argue that as physicians, as residents and as attending physicians, we have a huge role in the decision-making process as to what occurs during each of these admissions and what is prioritized as a problem, what is even discussed as a problem, and also what happens in the discharge planning stage. Because even if you didn't address it during the inpatient admission, there's an opportunity to make sure that that patient does not fall through the cracks after they're discharged. But at the same time, going back to that, so at an individual level, we can make a big difference for an individual patient. But I also think that we have a role to play in leading the charge to change the system so that it supports systematic identification of every patient who has malnutrition. Because again, to review that full quote, if you pit a good performer against a bad system, the system will win almost every time. We spend too much time fixing people who are not broken and not enough time fixing organization systems that are broken. Only leadership has the power and responsibility to change the systems. So This slide may be a little small for you to read, but I just want to review these 6 steps that were kind of released as this consensus statement in terms of what we can take action-wise for institutions and individuals. And I'll give you some examples of what we've tried to do as an institution and also at the individual level. So principle 1 on the left is create an institutional culture. Principle 2, redefine clinicians' roles to include nutrition. Principle 3, recognize and diagnose all patients at risk, and then rapidly implement interventions and continued monitoring, communicate those nutrition care plans, and develop a discharge nutrition care and education plan. And they give you some specific examples on the right, which are available in this citation. So here's some examples where we've tried to change the institutional culture. So we've started to hold an annual malnutrition awareness week activity coinciding with Aspen's malnutrition awareness week in September, and this was our most recent one, just held just a few weeks ago, in which we have a booth in the lobby, and we welcome folks, both caregivers and families, as well as staff, to stop by. And actually Sandy Fenwick, the CEO of Boston Children's, stopped by our booth on this day, which was great. And these are some of our project staff, as well as some of our dietitians and diet techs here standing behind a booth that has samples of the high-calorie smoothies that our hospital patients can order. And we tried some of them. They're actually delicious. I tried one that was orange creamsicle flavored. And then they were able to hand out recipes as well accompanying these smoothies. During the same week, we also engaged our food services and had them do some education around health benefits of nutritious high-calorie foods. We focused on the avocado for this example, and they designed some dishes that were served and sold in the cafeteria that emphasized this. Other things that we did, we actually held a measurement activity, and we engaged Child Life across the hospital that week to engage in measurement activities on every ward. And you see here a picture of the stuffed animals that the patients, children got to weigh and measure, and then we gave them cards where they could record these things, and then they got to take the stuffed animal home. And we also distributed buttons and stickers. That the stickers were for the kids that say, I got measured and I got weighed. They were sort of modeled after I got my shot today. And interestingly, some of the dietitians found that literally just wearing this button led to them being asked more at rounds about what is your input about nutrition for this particular patient. We also designed some growth charts that could be displayed at the bedside and could be a keepsake for the families to take home, but also could serve as a reminder to the inpatient team when they rounded in that room to make sure that it was documented. The other way that we can systematically identify patients who are malnourished is to screen them, and not necessarily using measurements, because measurements can be a challenge to get in a really timely way. And the process of malnutrition screening is to identify individuals who are either malnourished or at risk for malnutrition to determine whether a detailed nutritional assessment is indicated. And in 1995, the Joint Commission mandated that nutrition screening be performed within 24 hours of admission for all patients. And this process was to also include a full nutrition assessment for patients identified at risk, and that periodic rescreening must also occur at regular intervals. Now, since that time, the Joint Commission has qualified their guidance a bit to say that the nutrition screening has to be performed within 24 hours whenever it is indicated. But again, most hospitals do have a screening process in place that's predominantly carried out by nursing staff in response to this Joint Commission mandate back in 1995. So the ways that we can screen other than using measurements is to consider using a questionnaire. And there have been a number of validated screening instruments that have been developed for use in pediatrics. These are designed to rapidly screen, sometimes in lieu of measurements, although some of them also include measurements as part of the screening instrument. And they are generally completed by the clinician. And I don't really have time to go over all of the different tools, but here's just one example of a tool that is increasingly popular because of its simplicity. It's literally 4 questions, and 2 affirmative responses indicates nutrition risk. And you can see that these questions are very simple. 3 of them are designed to be posed as questions to the family, and the last one is actually just a ballpark assessment by the clinician. So there currently isn't a consensus on which validated screen is the best to use in pediatrics, but I think that we should still consider using one based on what you feel is the best considering the data. And there actually are data to suggest that if we introduce a validated measure like this, that it can improve the rates of measurements, it can improve our response during the admission, referral to a dietitian, and improve dietary management and monitoring. So a simple measure, again, that if it can be implemented in a systematic way, can potentially improve patient care. And there are actually not very much data at all about how hospitals screen in response to this Joint Commission mandate, despite the fact that the mandate was established quite a long time ago. So we recently conducted a survey we attempted to identify every U.S. pediatric hospital, and we've identified close to 250 hospitals, but this is a preliminary version of those data. And in this preliminary version, 34 of 95 hospitals, 1 in 3 did use a validated screen, but it was highly variable what was used, and of the screens that were used, the PNST, the version of screening that I just showed you, actually was the most popular. The MST is actually an adult screening instrument, and we haven't looked at these data closely, but my guess would be that that might be influenced by pediatric hospitals that are within an adult hospital as opposed to a freestanding hospital. And also, interestingly, over half of these dietitians wished that they could change their hospital's nutrition screening process. Many of them wanted to try to implement a validated instrument. They felt their criteria or their process was not valid or inaccurate. They wanted to try to automate it, improve the accuracy, make it mandatory, and also increase the number of staff who were able to screen patients. And this is an example highlighting where, even though we don't necessarily know exactly which way to do things is the best, sometimes doing something can actually be super beneficial, even if you're not there yet from a quality improvement standpoint. So in our NICU, we fairly recently implemented a standardized enteral feeding advancement protocol. And what we found is that when we did that, we were able to substantially shorten the amount of time that it took to get to 100 mLs per kilo per day of enteral nutrition. So you see the median line at baseline was taking 6 days, and that became reduced to a median of 3.4 days after we introduced our protocol. And actually, if you go back to 2005, there was a meta-analysis published back then that showed that there were several studies where they had implemented a standardized feeding protocol in various NICUs, and these feeding protocols were all different. None of them were really, they all incorporated different principles, and what they found was that all of them reduced the incidence of NECs. So, and the reduction was like mind-blowing. I mean, it was 87% reduction. And so, so what this is telling us is that despite the variation across NICUs, if you reduce unnecessary variation in the context of your own institution, that potentially can have a really beneficial effect. So moving on to what we can do and ending with the individual actions that we can take if you have a patient, that you're currently dealing with. At rounds, we can systematically try to include discussion of nutrition, identify and address those barriers to nutrition delivery, Make sure that you monitor and manage refeeding syndrome. And if you have a procedure that that patient is scheduled for, and you're dealing with a really severely malnourished patient, think about whether it makes sense to actually rehabilitate that patient's nutritional status before doing a procedure that's not urgent. Obviously, for something that's emergent, you have to address that, but if it's not emergent, it might make more sense to get their nutrition into a better state and lower their risk of complications associated with doing that procedure. Also, it's really important for primary teams to discuss malnutrition as an actual issue with the family. In Boston Children's Hospital, we're fortunate enough to have a nutrition support service, but it's frequent that we run into the issue where we're the first ones to bring up malnutrition as a problem, and if it's never been mentioned by the primary team, whether it be cardiology or anybody else, that family is not going to perceive that as an important issue. They're going to be like, why are you the first people to bring this up? If it was really important, someone would have brought it up a long time ago. So having that buy-in to actually address this is super important. A discharge plan should include nutrition. One other question to consider is if they're super severely malnourished and they have failed outpatient therapy, should you consider waiting to discharge them and really addressing nutrition explicitly as an issue? Again, what we're hoping for is that identification of malnutrition and effective treatment is actually going to reduce length of stay eventually, but if you end up with a situation as dire as the patient in our case, it might have benefited that patient to have stayed in hospital for a few more days in one of the previous admissions so that they didn't have to be in hospital for 3 months at the end. Also making sure that if they're tube fed or if they're dependent on specific formulas or supplements, to make sure that there is a discharge checklist that has included all of those things that they need prior to leaving the hospital. Here's an example where one of the MSICU staff, Nilesh Mehta, who does a lot of work in nutrition in the critical care population, looked at what are the barriers to nutrition therapy in the ICU and what percent of them are avoidable. And 50% of the interruptions to enteral nutrition delivery were avoidable. Many of them were things like constipation and not having a set protocol for dealing with constipation, longer than needed NPO time for different procedures. So there is stuff that we can do as physicians as long as we have the awareness. And again, this speaks to both your individual patient, but also system things. If you don't have a protocol for constipation and dealing with it, or don't have a protocol for deciding when gastric residuals should really influence whether you advance feeds or continue them or not, that's going to lead to individual providers not having the data that they need to be able to make those feel good about the decisions that they're making. Finally, just checking the growth chart. Again, it sounds really simple, but just having an awareness of what did this patient weigh and where did they plot? Were they actually at risk when they first came through the door? And does that make them at greater risk of weight loss or inadequate malnutrition or inadequate nutritional provision during the hospital stay? So being cognizant of that, also being aware whether the initial weight that you have recorded is an estimated versus a measured one. Certainly in our hospital, we've had errors that have occurred from measurements that were estimated in the emergency room that then were perpetuated without anybody ever bothering to remeasure that patient when they got to different places in the hospital, and finally figuring out it was off by a huge amount. Also looking for physical signs of wasting during the physical exam, and then finally diagnosing malnutrition as a problem in the problem list and also for billing purposes, because documenting malnutrition actually leads to it can lead to better reimbursement and better documentation of the complexity of care that you're providing for that patient, which also has implications for the hospital as a whole in terms of how it's regarded with regard to acuity of care. And we just implemented a simple malnutrition care plan order on one of our pilot units, and what we showed, actually 2 pilot units, And what we showed is that on one of the units, it was actually a unit where malnutrition is typically an admitting diagnosis, because they're typically being admitted for advancement of placement and advancement of NG tube feeds. They were actually doing pretty well in terms of documenting malnutrition when it existed. But on the other unit, which was actually a critical care unit, they were not documenting malnutrition well at all. And so with the simple proposed malnutrition care plan that was proposed by our dietitian and sent to the physicians, they were able to document the appropriate billing codes well. So to finish off, malnutrition is common in pediatric inpatients, and early detection has the potential to improve health outcomes and reduce hospitalization costs. Detection needs a systematic approach because it's easily missed. The diagnosis requires measurement, ideally multiple measurements over time. And if we are going to make sustained improvements in diagnosis and treatment, it requires a multidisciplinary, multifaceted approach at both individual and institutional levels. I have a lot of people to thank. One of the most gratifying things about this project has been the ability to meet and engage with folks at all levels, and we have excuse me, a really committed group that have formed our steering committee for the Malnutrition Quality Improvement Project. But also the people on the front lines are really our champion teams, and that's been comprised of physicians, nurses, dietitians, nurse practitioners, and clinical assistants who have really been engaged, and it's been really gratifying to see their level of engagement with this project and their commitment to improving malnutrition detection and treatment in our patients. Thanks very much for your attention.
Time for 2 questions. Yes, go ahead, Dr. Patel.
Given the accuracy of MidUpper Arm Circumference, why don't we use that to avoid all the problems of height and weight and boards and all that?
I think it's a good question, and it's actually an area of controversy right now for the World Health Organization. I think that my standpoint is that they probably measure complementary aspects of malnutrition, and so having both is probably beneficial. But honestly, I think some of it is part of a cultural issue, and one could make the argument that maybe in the critical care setting, should we be trying to use mid-upper arm circumference more, for example, instead of trying to obtain lengths on patients who are vented and really shouldn't be moved from a hemodynamic stability standpoint. So I think there is a growing awareness of the value of mid-upper arm circumference, and I think you'll see more of it in the years to come.
Dr. Baldrige.
Did you notice if there's any difference in whether hospitalists and care teams were involved in better detection and nutrition on certain patients in their institution?
It's not something that we've looked at all. Yep, thanks.
Thank you so much for this.
Thank
wonderful
you.
talk.
Okay.